NHS long-term plan, although my understanding is that the medium-term strategy will be a document, internal document for NHS England. It won't be an outward-facing document in the same way that the NHS long-term plan has been. And obviously, as many of you will know, the long-term plan had some specific elements in it around carers. Our hope is that the medium-term strategy will also have some carer elements in that, but that won't be available till later this year. So those are the key things for us. The other thing that I would note, and it's relevant to some of the speakers we're having today, is that reports on carers, and we've just heard from a book that's just come out that seems to be every few weeks or every few months a new report around carers, and I would alert you to the Health Foundation report, which we have some speakers today talking about from the Network Data Lab, which is some really very interesting evidence they put together. There's also been a recent report from the King's Fund, which we'll probably try and put into the chat as well, and a wider ranging report about carers and care workers from Oxfam around terminology and how the dialogue around caring needs to change, if you like, which I think many of you will get some interest from as well. So I think Verity's on next. We're talking about data, and that sometimes is a bit of a switch off for some people, but it really is fundamental to where we are. And if you looked at the recent social care document that came out just around Easter, there's a real push to get social care data improved in terms of transparency, in terms of how it's commissioned, in terms of how it's understood. And at the same time, there's a lot of linkages going between health data and social care data, and that really is very much in the remit of carers, because clearly carers inevitably bounce between the two, health and social care. So linking those up is really, really important thing to do. I'm very pleased to say that we've made some, what I believe to be some very good advances in that, maybe early steps, but some really important steps. And Verity will be able to tell you a lot more about that. And our speakers later from an ICB in the Southwest and from the Health Foundation will be able to give you some more detail as well. So thank you, Verity.
Thank you all. And Steve, if I could have the next slide, which should have the volume and a video, hopefully. Basically, I think, as Paul said, it's really great to be here today and hear about and kind of discuss the good practice when it comes to making use of unpaid carer data to drive those improvements. And it feels really timely because this week, the GP extract service, which links to the core contract, has made data available for all GP practices in England. And we know that there's loads of great work happening in the virtual room and sharing what's working and the challenges as well, because we acknowledge there are definitely challenges, is great. And I wanted to start with a carer story, because as Paul alluded to, sometimes talking about data means that we feel slightly removed from the human story and the purpose of the work that we're doing with regards to data. And a huge thanks to my colleague Jodie, who was the one that put this together. So Steve, are we in business, Steve, do you think?
I was just waiting for you to finish, then play it.
Thank you.
It's pretty pants, and no one prepares you. My husband had a freak accident and ended up with a clot in his neck that moved into his brain, which resulted in a stroke. He's completely dependent on me to make sure that his life is as flexible as possible and he can access things. But with that dependence on me goes a huge amount of responsibility for me. And the biggest thing that I really struggle with is that if anything happens to me, who is responsible for him? I've got, what happens if anything happens to me? I've got one of these lovely plastic cards in my wallet, which I realised the other day, since I don't have money anymore, I use my phone to tap to pay for everything. I don't carry my wallet. If I was in an accident, nobody would know that I'm caring for somebody. I've got nothing on my phone. I've got nothing that says that I'm a carer. I need to have a tattoo or something. When they strip me off in A&E because I've had a car accident or something, it'll be tattooed on my shoulder. I'm a carer. There's someone at home waiting for me. I've got sitting in my inbox at the moment is the revision that I need to do. But the biggest challenge I find is that every time I have to talk about my husband's disability, every time I have got to tell somebody why it's challenging and why it's difficult and why there needs to be this certain level of care being put in and what needs to be picked up, I have to go through all the disabilities. I have to go through everything he can't do. I have to re-engage with how disabled he is and how life has changed completely, just so that somebody has that information, so that if anything goes wrong, that person who then becomes responsible for Graham, that they know what they're doing. Got to make sure that he's safe if something happens to me. But it's really hard to get all of that information in this short little plan, because every day I'm with my husband is different. Every day I don't know what his anxiety is going to be like. I don't know if he's going to be able to take his medication or not. I don't know if he's going to be able to talk or not. I don't know if he's going to be able to understand or process what I'm doing. And how do you put that into a document for someone to pick up if something happens to me, to then go, oh, I know how to look after this person and we know what to put in, when even I don't know from day to day what's going to happen. I'd much rather it wasn't happening, to be honest. I would much rather not have to write a plan.
Thank you, Steve. If I could have the next slide. Whilst I'm waiting for Steve, I'll carry on. I think what's demonstrated really clearly by Joe is that it's really essential to be identifying these carers and also sharing data and information across systems so that they don't have to repeat themselves and repeat their story. And we really want to, part of the long-term plan commitment has been around ensuring that carers are recognised, identified and supported, and part of that is to sort of maintain their own health and well-being. And the NHS operating framework makes really clear that ICBs are responsible for the kind of the delivery of the NHS long-term plan. And as you'll all know, there are 2 long-term plan commitments for unpaid carers with really clear metrics. So I won't read them out, they're on the screen for you to read. But another central focus is around unpaid care identification, with particular regard to carers who are known to be especially vulnerable. So we know carers are vulnerable, but those carers with kind of protected characteristics as well, which might increase their vulnerability and kind of deprivation levels. So I also wanted to take this opportunity to mention that care identification and support is also central to a policy initiative called the Dynamic Support Register, which some of you might already be aware of. And the register aims to prevent unnecessary hospital admissions for people with a learning disability and autistic people. And we can share the link to the policy, but all ICBs must have a dynamic support register. And at its heart, the register is about an integrated whole system approach to enabling greater and more focused awareness and empowerment of people with learning disabilities who might require proactive support and intervention to maintain their health, well-being and quality of life in the place where they live, so avoiding admissions. And part of the policy with regard to the dynamic support register includes identifying unpaid carers and recording this on the dynamic support register. So it's another area where there is carer data being captured, and the CQC are taking into account care identification and whether carers have a contingency plan within some key lines of inquiry. So that's also a relevant area. If I could have the next slide, please, Steve. So as well as being embedded in a number of department policy priorities, as Paul's already kind of spoken about, there are also really clear duties within the Health and Care Act to secure continuous improvement in the quality of experience, and also involve unpaid carers in decision making with regard to service development, prevention, treatment and diagnosis, as well as some specific requirements at hospital discharge. So if systems don't know who their carers are, meeting these duties will be very difficult. And as we all know, lots of different partners within the system have information on carers that are identified. And there's obviously work to do to support the identification of those carers less likely to identify for a host of reasons that we're aware of. If I could have the next slide, please, Steve. Thank you. So as Paul's already mentioned, there have been major studies by independent organisations such as the King Fund and the Health Foundation, who I'm delighted are going to join us today, the Nuffield Trust and Oxfam, which all show that energy gathering around the importance of identifying, recognising and supporting carers, and also how essential it is to know who our populations are. So we know that those multiple data sources make clear that unpaid carers have worse experience and outcomes, and that this is exacerbated when carers are also from a protected animal health inclusion community or from a deprived area, and that the core 20+5 approach is relevant to unpaid carers. And we know that some of you are absolutely kind of prioritising carers within your core 20+5 and population health management approaches. So it'd be really good to kind of hear from you in the chat how you're doing that, and where you are doing that, so we can have a think about next steps and how we're sharing that. If I could have the next slide, please, Steve. So as we've kind of alluded to, robust data and qualitative insight is really central to this quality improvement piece for our unpaid carers. And it is essential that carers are supported to identify themselves, and we see primary care as having a pivotal role in identifying those carers, particularly those who are less likely to identify and recognise themselves as carers. And those are communities that won't be reflected in the data, and they might not be known to other services. And we have produced guidance and a letter to support primary care to code carers in primary care clinical records in a consistent way, and worked with stakeholders to ensure that the existence of contingency plans are, when they're coded, automatically coded into the summary care record for an emergency, so anyone across the system can see the existence of that contingency plan. If I could have the next slide, please, Steve. So I'm sure most of you will have seen the guidance and the information, but I think the key takeaway within the guidance is that actually, as a minimum, there's an expectation that systems would be able to report how many unpaid carers are registered in primary care, including young carers, and of those, how many have a contingency plan in place so that professionals can access them. And again, we can share the slides and the links to the guidance if that's helpful. If I could have the next slide, please, Steve. So as I referred to earlier, there's now a single indicator in the GP contract extract. So at the moment, it's a single indicator. So it doesn't capture as much as we would like at present. So we don't have the number of contingency plans coded, or who the carers are. So thinking about cross-cutting the data with populations, but it's something that we're prioritising and having conversations about. So the purpose of the data that exists is to compare data from across England and allow the data to be turned into kind of accurate and usable management information to drive those improvements in patient care and support efficiencies across the service as a whole. And yeah, that is enough from me. I'm really keen to hear from everyone else how they're kind of making use of their carer data and sharing information, and hear from colleagues at the Health Foundation about what they've learned. So I'll hand back to Paul.
Okay, I think there's a comment in the box from Harriet. Is it a question that you're happy to share in this environment, or do you want to do it offline? Just asking you, Harriet Stevens.
Yeah, I was just asking who the contact is for this new core GP contract data that you're talking about now, just because I saw it yesterday and was really excited about the possibilities from it actually. So just wanted to clarify a few things and ask some questions, and just wanted to know who the best contact for that was.
Yeah, so my suggestion is that if everyone who has questions sends them to our team NHS Think Carer inbox, then I can collate them and go and have a conversation with the policy lead, because yeah, I have some questions as well. So, and then I can bring that back to this group if that sounds okay.
Great, thank you.
Okay, any other questions specifically around this? Appreciate there's a lot of information there if you're new to it. But clearly, if you do have any follow-ups after you've considered some of this information, please do send it in as Verity has described, because it can form part of the next steps with this.
Hi, Paul. It's Tom from BMK.
Yes.
I've just got some observations of what we're doing locally with data. So I've got my business intelligence team to run a report at practice level so we can see how many carers have been coded. But what we've also done is, in addition to that headline number, we've got them to look at a rate, so rate per thousand population, so we know which practices are doing it well rather than just a number. And then in addition to the number, a recent development they've just done is they've put an extra column on that data sheet for newly identified carers. So if in quarter 3 we had 100 carers identified in a practice, and then in quarter 4 we had 100 carers identified, that wouldn't really tell us the full picture, because we wouldn't know if they were the same 100. So we're getting an extra column so if an extra 10 have been newly identified in that quarter and 10 have fallen off, we can look at that intelligence to see if practices are proactively and continually identifying carers as part of their routine care.
Yeah, that sounds excellent. Anyone else want to comment on that? Doing anything similar?
I will follow up with you if that's okay. That's my request, Tom, if that's all right with you. And I also saw Tim on the call, and I think they've been doing some really interesting things. I don't know, Tim, if you're happy to reference the work that Kevin's doing in your team.
Verity, I'm going to jump in because Kevin's on the call as well. So if Kevin...
Oh, Kevin. Sorry, I didn't realise. Kevin, you definitely talk about it as you're the one doing.
So in terms of the work that we're doing for carers in we're trying to map our carers and do a bit of working in, at a place level. So that's West Heart at the minute, to kind of understand their impact in terms of readmission, the risk factors and risk profiles, and try to support that whole proactive targeted approach to kind of prevent some of that work. Is there anything specific that it's to be honest, I was multitasking, so I wasn't really following everything that was going on. So I'm just trying to catch up as well.
there was a question in the and a reflection actually in the chat, Kevin, about how you can use that data to triangulate it potentially with the census and your population to undertake a bit of a gap analysis. And I think that's what you're doing, isn't it?
Yeah, so the census was hugely, really illuminating in terms of where our potential unreported carers are and how that maps into the data systems at primary care level. And I think there's lots of work that needs doing in terms of coding that correctly at primary care so we get a good understanding of the health. And I think we need to, it's not just about that coding, I suppose, it's just more about that promotion and that linking in with wider groups as well to try and just get that offer out there. Carers and Hearts are doing fantastic work around that, and I think and a lot of other organisations and agencies are doing that, and I think it's just about how we map that and align that and use the data proactively in terms of like admission rates for carers who are 50+ hours or more, which we have data on that to suggest that there's a high admission rate for carers who are providing 50 or more hours, how we can be proactive and kind of supporting them away from, well, not to be admitted first and foremost, but also to kind of keep that and keep them in their care responsibility, but be a bit mindful of their specific health needs and kind of how we maintain them being well for longer at home and kind of support them proactively. Yeah, did that answer the question? I hope so. I did. I'm on a bit of the hop there.
Definitely.
Oh, we had Lizzie with a hand up. She might have a question, or it's the same one that was in the chat box. I'm not sure.
Yeah, well, I think Tim's just confirmed my question. So my question was the data that's been pulled out, is that using the codes that we saw on the previous few slides? And I think, am I right in saying yes? Yeah.
So the codes on the previous slides are the most commonly used slides, but the indicator, which is the GP extract data, is from a broader number of codes because we didn't want to underrepresent the number of carers coded. So we're saying that's kind of a consistent way, and they're the most commonly used codes. But actually, there's lots of codes, and carers are coded within those. So the indicator is broader than those codes that you've seen on the slides.
Okay. Yeah, because in Dorset, we're encouraging our practices to use patient themselves provides care.
Yeah.
And we wanted to see if, since we've been promoting that code, if there had been an increase, and hopefully using the data that we've seen today. So that's really helpful. We've compared it to some of the data we pulled off in Dorset in our DICE programme, and it's really similar. So I'm hoping that we're getting the right codes as well. Thank you.
No problem. I can see one more hand up.
Hi. Hello. If it's okay, I just want to ask a question about in terms of how are these codes being translated in acute hospitals? Just because I remember the first time I joined this meeting and there was a lot of discussion so that we could identify the carers better. And I realized very quickly with the systems that we have within our organization, we don't have a way to translate that at the moment. So what I've done was I worked with our digital team and created a pathway to identify carers using our patient records. But it's how then do I translate that? Because at the moment we're gathering quite good numbers. Ever since it was launched, it did take a good 3 months for it to be embedded, but now we have an average of 200, about 200 amount of cared for patients in hospital, and maybe between 10 to 15 actual carers admitted themselves. So I must admit, I did feel like I unpacked a whole Pandora's box because I'm now almost backdating. I need to build my team faster so that we can meet the demand, because the aim is for all of these patients and their carers to have the appropriate referrals, to have been signposted to care organization if they want to. But I just want to see how can I relate that into the GP coding later on once I met my demand. Any recommendations?
So I think this is one of the challenges and something that we're really keen to think about in terms of next steps. So actually within systems, lots of organisations from kind of across health, social care and the voluntary sector have information on kind of who unpaid carers are and how they're identified. And I think it sounds like you've done amazingly to kind of think about identifying and supporting those carers, but there is definitely something about, and that's almost within the next steps for this work, how we as systems are collaborating and sharing to identify carers where they're appearing in systems. So I know that in London, they've got a letter, like a standard template letter, which they're using for carers to say, please code me on my primary care record. And in other areas, the development of, and again, there's some really good work in Surrey and London on this, to embed carer identification and those contingency plans within the shared care record. So, for example, if a carer does pitch up in hospital, you know that they're a carer, but you also know what needs to happen to ensure that the cared for person is safe and well, to kind of prevent that double admission, which is really essential if Kevin's understanding of the data in terms of that admission rate is even higher, if you're a carer providing a lot of care. So I think there's lots of different ways that this is being done, and as part of the next steps, it'd be really good to kind of connect in with you and share what you've been doing. Go on, Kevin.
I'd like we triangulated with our BI team around the physical health component in terms of a lot of carers were more likely to suffer with hypertension and be prescribed antidepressive SSRIs or even be coded as having depression. So we triangulated all that data in the background with the outcomes and segmentation model. And because we have a linked data set that's a bit more mature in our South and West Herts place than we have in other places, we were able to link that specifically to hospital admission rates. And again, there's still work. Nothing's perfect, but it gives us a bit of a targeted population that we can do some work with. You know, it's that 50 hours plus the population that we're looking for. We know that's bigger, according to the census information, in South and West Herts than what we have coded at the moment in our outcomes and segmentation model. So there's work both to do promotion, to do recognition, to do that, get that true analysis of whether or not the health needs are as appropriate. But to do that whole kind of that piece of work to keep people out, but recognise when they are in hospital. So that work that's happening when they're in hospital, which I think her name escapes me. I know her name off the top of my head. Angie. Was it Angie? She's doing fantastic work on West Arch Teton Hospital. Her name escapes me off the top of my tongue. But it's how we join that all up as a system, and we're looking to do that at the moment in terms of further conversations with our BI colleagues who are supporting this work to do a bit more targeted intervention, targeted work. So it's how that whole picture in terms of how we started, which was starting at what are the health needs, I think, and then we drilled it down to, okay, now who do we need to do a bit more? So that data at the heart of what we were doing to drive it forward as well. But that elaborates a bit more, probably talking circles.
Yep.
Andrea Hone, that's the one. Yeah, sorry.
Yes.
Thank you. We might invite you along, Kevin, to another one if to talk in a little bit more detail about the work you've been doing, if you'd be up for that in the future. Thank you. Sorry, Paul, I'm made your chairing really challenging, but anyway, I will stop talking now and we can go to the next.
I think, so the only thing that I would add in there, I mean, the question that came up, hospital systems, as I understand it, don't use SNOMED codes, but that doesn't mean they can't be linked to care identification within hospitals. So there isn't a direct linkage, but that doesn't mean it can't happen, if you see what I mean. They use different coding, and certainly some trusts have been using their own coding for carers within hospitals, and obviously the ideal is for those to be linked up at some point. So as people have said on this call, people are pre-identified before they come to hospital as being carers, whether they are with the cared for person or whether it's for their own health needs, so that those things are connected. And that's certainly the way things hopefully will progress in future. Jacqueline.
Hi, so I just wanted to come in there around the interface between the community and the acute settings. So we here in BSW, we've looked at that slightly differently, and we've shared our list from our carer centres, of those who have carers cards, and one of my colleagues actually in the quality team supported the acute in Swindon to add this to the patient records. So there is an awareness between the acute and community if those individuals were to come in that they are in fact a carer. So that's how we kind of got round the difference in the interface.
Yeah, thank you. That's very helpful. Andrew.
Hi, I think it relates to the carers passport scheme within hospitals. I know that Somerset are pushing ahead with that, with their ICS and ICB, but also getting representation by carers on the ICS and ICB boards.
Thank you. Sounds like progress, which is excellent to hear. And
yeah, I think the carers passport scheme is national, though. I think various different areas are doing it in different ways, but it's coming from the community, making links with the system rather than the system reaching out so much.
Sure. Okay. I think we now is a good time to get some information from Bath and North East Somerset ICB regarding their data sharing agreement. That's one of the things that people struggle with sometimes, and it's something that can be very difficult, but people have found ways around that. And as we've already been discussing here, it's about sharing key information appropriately with the appropriate permissions, etc., etc. So, Jacqui, if you're ready and willing to go, over to you.
Fab, thank you so much. So that would be me again. So just to introduce myself, I am the carers lead, or rather I'm one of the carers leads. I support our Director of Quality, and I come from BSW ICB. So we're quite a large organisation. So we cover the whole of Wiltshire, Swindon and Bath and North East Somerset. I'm very fortunate today to have two of my colleagues from the BI team on the call. So hopefully when we get to the questions and queries at the end, we as a triumvirate should be able to support you all. Can I have the next slide, please? I'm happy to share my screen. Oh, awesome, it works. So to kind of explain a little bit about how we ended up as BSW, I need to take you back a little bit to the history of our organisation. So previously, we were in fact 3 separate CCGs. So we were Bain CCG, we were Wiltshire CCG, and one in Swindon. So we were very fortunate to have a team member working in the Bain space who had a fantastic relationship with many of the practices due to previous work that individual had done. So we started off with one reporting unit, and the request was to get practices to sign up to agree to that. So the work was started with each of those practices and the local CCG at the time. There was lots of meetings with the practice managers to explain what the system did, what we could see and what we couldn't see. And also we agreed to share every single thing that we would pull from that system with those individuals along the way to see exactly what had been pulled and to ensure transparency, that we weren't going into their systems and looking at something that we couldn't, that we were going to use in a different way than we said that we were going to do. After about 18 months, the queries from the practice managers stopped, and the separate report that was being shared with them, our colleagues basically stopped pulling because everyone was confident in that area that we were using that data as we should have done. So when we amalgamated into one CCG, which became BSW, the work then basically was adopted across Wiltshire and across Swindon. So we don't have total saturation. There are still practices in Wiltshire that have not signed up to the data sharing agreement. However, we have more practices who are than aren't. So on the whole, it took a lot of time. We were very fortunate at the time that one of our colleagues was doing it. There were in fact 2 work streams, so this one and another one, that were involving primary care. So there was support with pooled resource, so that also helped with the process, but on the whole it took about 18 months. So do you want to show me my next slide, please? So it's just basically the key points from that is to emphasise what the practice can get for it. If individuals don't see the benefit of how we can support them, they are not going to give us access to their systems. It will take time, and we're not planning on getting 100% saturation. We don't have capacity at the moment to reach out to those individual practices to ask them to sign up, but there is a requirement with this work, particularly at the beginning, to build up the credibility, being open and being transparent about that information, and giving them the opportunity to opt out. It's not mandatory that they have to share our information with us. It is positivity for building a system working. And that was very much the foundations for where we are currently now, working as 3 separate ICSs. So that's quite positive. The last slide that I've got here is actually how we physically pull our data from each of those systems. So I didn't know if either Lee or Sophia were happy to talk to this one.
I can jump in, but to be honest with you, I think it's, judging by the conversations that have been going on in the background, a lot of you guys are way ahead, certainly far more mature than we are as a business intelligence team. I think really we're just pulling obviously the data from primary care record. We're very fortunate, as Jacqui mentioned, that we have data sharing agreement with the vast majority of practices, and also we're very fortunate that the majority of those all use the same primary care system, which is system 1 in this case. And yeah, we've got a standard set of reports that we've developed, so we know the recodes that we need to use to obtain the unpaid carers, as again was Verity popped up on the previous slide, and those with a contingency plan. But again, we also have, because there's so many other codes that we've also added as well, because we want to be able to get more data out, understand that cohort in more detail. So yeah, we're a standard approach where we just use reports, predefined reports. We pull the information, and we just, at the moment, because it's done pretty much on an ad hoc or quarterly basis, we don't have an automated, we don't warehouse it, we don't put it at the moment into a warehouse or put a fancy report on it just yet. We just do some very simple transformation enhancements, and using Excel, as probably the majority do. And I think as we mature more, we will look to probably to warehouse this, build some Tableau or Power BI reports on that. But we will start looking at other triangulating this data with other data sets, as you mentioned, looking at population health and that kind of thing, and seeing what we can tease out of this information. But I think, yeah, it's a journey that we're just kind of embarking on. And again, sounds like, Kevin, you've done a lot of really interesting work that we could probably benefit from your expertise, or some pointers in the right direction, how we can move this forward. Thank you, Jacqui. I didn't want to read the slides. Sorry, I didn't want to go through the slides. I'm sure, as I say, this is probably common to a lot of people that are using the primary care record to extract data. So I don't really want to, teach your grandmother to suck eggs.
Yeah, no, I completely understand. So on the elements that we have just briefly discussed, the only thing that I realised that I've not included in the information here is what the data sharing agreement actually says. So I can share that, but I'm pretty sure it will mirror what you guys already have in terms of terms and conditions, etc. But I'm more than happy to share that. Are there any questions on the journey that I've just described?
I think if not, I think we need to move on fairly quickly, because we're getting a long way down the agenda and we haven't let our Health Foundation people speak. So sorry to rush you on a bit, and people will think of questions and we can follow up
Fab.
as we've described.
Thank
But
you so much.
I'd really like, thank you very much for a very interesting presentation. Can we then go to the Health Foundation? I'm not sure whether Hannah, Sebastien or Chamut are going to be picking up first. Thank you.
Hi, Paul. Yes, this is Seb. I'll be presenting.
Okay.
Yeah, excellent. Thanks for the introduction and Verity for inviting us. I feel like I have to apologize because this will be very data focused, but hopefully still interesting. So yeah, Hannah and I are here today to present the work we've been doing on unpaid carers, specifically on how we can use existing electronic records to identify them. At the end of the presentation, we will have some questions for you because I'm hoping that you can also help us interpret some of the most recent draft findings. So if that's okay, why don't we skip to slide 17 because we're a bit short on time. I'll tell you when to stop. Yeah, that's fine. Next one, please. Yeah, so in the report that Paul shared in the chat, we did quite a lot of analysis using openly available data, so things like the census, local authority returns, and DWP data. But these data sources are useful for resource allocation, population planning, but they're not very useful for targeting specific individuals or reaching out to specific carers. So I'll show you some work that we did with 5 local authorities in England and Wales, where we enabled some new data linkages to try and push the boundaries of what electronic records can tell us about carers. So this was a strand of work done as part of a Health Foundation program called the Network Data Lab. What we do is we tackle a different topic once a year, and we work with a range of data owners across health and social care to enhance those local data sets. So for this project, we tried to get local authority data on carers from about 20 councils, and in the end, we were successful with 5. Could give another presentation on how difficult that was, but in the end, we ended up with local authority and health data from Liverpool, Wirral, Leeds, Neath Talbot, and Swansea. Next slide, please. Yeah, so what data did we obtain and link? We got carer assessments done by the local authority or their subcontractors, support packages given to carers by the local authority, people's personal information like their name, their address, and also their GP and hospital records. So what's novel here is that we were able to link all of these data sets together using people's NHS number, or if that was missing, which was very often the case because you don't always ask for people's NHS number when you're providing local authority support with probabilistic algorithms that use their personal information. But what this means is that we were able to follow the same person through their pathway of using different NHS and social care services. And we were able to identify carers in 2 different ways. So one, with SNOMED or read codes in their GP records that indicate that they're carers. So that's some of the work Verity was talking about. And 2, if they were present in the local authority data sets as having asked for an assessment. So that would indicate that they are a carer. Next slide, please. So this is what we set out to do. We wanted to count how many carers we could find in each data source, and then quantify how much of an underestimate that is compared to the census findings, which is kind of the gold standard right now. And then we also wanted to use that data linkage to see whether GP records and local authority data sets were finding different people. We also had some more ambitious questions that we wanted to look at, but things like waiting times for services and inequities, but that was very difficult because of data quality. So next slide, please. So our first finding was that, no surprise, electronic records undercount the real number of carers by a very wide margin. And in the graph you're seeing here, so the red bar in each area is the estimate from the census, and the blue and purple bars are the number of carers in the GP and the local authority data set. So the counts are so small compared to the census that you can barely see them. The next step was to compare the two numbers, but that in and of itself is a bit difficult because someone who answered the census in 2021 and said that they're a carer is not necessarily the same group of people who can be found in records, either because they might have moved areas or maybe they stopped being a carer at some point after being identified and before answering the census question. But nevertheless, we gave it a go. We assumed it was the same group of people. We also widened the look back period to a window between 2016 and 21. And if we do that, what we found is that these records only find between 11% and 26% of all unpaid carers, depending on the area. Next slide, please. Yes, the second finding was that GP records identify a lot more carers than the local authority records. So in our pilot areas, it was between 2 and 15 times as many. And also what really surprised us was that there was very little overlap between the two sources. So this was consistent across all the areas. So these two Venn diagrams are for the two Welsh locations. And next slide, please. This is for the 3 English ones. So you can see that the same pattern emerges. Next slide, please. Yes, we also wanted to compare the demographics between the two groups very quickly. They were very similar in terms of sex and in terms of local deprivation. However, the carers you find in local authority records tend to be older than the ones found in GP records. And our working hypothesis at the moment, based on our engagement with the data owners, is that perhaps these older carers have more support needs and therefore are more likely to ask the council for support and therefore show up in that data set. Next slide. Thank you. Yeah, so you probably have a few minutes for questions. Like I said, if you don't mind, we also have some questions for you because we are drafting a short report using these findings. So we're keen to hear your thoughts on the points that I've listed here. Maybe we can stop sharing the slides just so we can all see each other. But I'll paste the questions in the chat. So basically, if you had really good data on carers, what would you like to investigate? If you could personally identify them, what would you do with that information? And finally, why do you think the two groups are? Why do you think the two sources are finding different groups of people? And I'll stop there.
Okay, Andrew, you've got your hand up.
Yes, I've got a number of questions really, but firstly, the local authority figures, are these based on assessments?
Yes.
Well, there's your gap. Most conversations I have with people is they don't identify as carers until 2 years into a caring role. They identify as mothers, daughters, fathers, sons, family members, and the perception is that that's what people do within society. The gap as well is that there is a conversation that's had with a GP. There are different conversations that you have that come up. The statistics gathered in the census were skewed because of the questions. They're totally wrong. And also the value of care. If the value of care is the amount of time that a carer takes, then that is wrong, because it may be 8 hours of critical care that they provide, as opposed to 50 hours of general care being in the same house. You know, it's just I'm find myself becoming a little bit not angry so much, but there needs to be more done where the community figures are out there. We're seeing the results in the community, and it's good for the system to be reaching out to it, but it needs to be embedded as an automatic question. Without question, are you a carer? You know, and then from that question, a similar range of questions as to, well, you don't consider yourself a carer, but you're doing this. Now, I know that the problem is that if you identify, you have a statutory obligation then, and that comes in, and it comes into resources, and it comes into budgets, and it comes into allocation of those budgets. And I realise the reticence to identify, basically, because carers are just overlooked. They're not hidden, they're overlooked. That's just the voice of a carer.
Absolutely, thanks, Andrew. I mean, yeah, these data sources come with huge biases for the reasons that you brought up. And it's important to acknowledge those.
Campbell, your hand up.
Thanks, Paul. Sebastien, that's really, really, really interesting and really useful. Those gaps in those graphs are mind-boggling. And it reminded me, yesterday I had the pleasure of a conversation with a group of practice managers in North Tyneside who are doing some activated work with regards to their work with carers. And one of the big things that's coming across from that work is the benefits to better identification of carers, getting them in, doing annual health checks. And what they were saying is that through those annual health checks, they're acknowledging what we know from the GP survey, that this is a population more likely to have longer term conditions, more likely to have untreated mental health issues, more likely to be isolated. So there's not only benefits to the carer of having those conversations, there's also benefits to the practice, because a lot of those interactions that they have are quaffable. You know, there are payments. So again, it really does sort of build the snowball with regards to the benefits. And I just wanted to thank you for your evidence, because what it does is it gives us a really clear business case with regards to those gaps. And I think my final point would be, what would the recommendation be from your team with regards to this evidence? Is it to continue the work, to, as Andrew talks about, to help people identify themselves as carers, given the benefits of doing so?
Yeah, thanks for that feedback. Absolutely. I think we need to give evidence to point out the gaps in all of these data sources, and that the evidence just isn't out there. And it was so difficult getting those two data sources and being able to link them. So I'm happy that people can, that we can point to those findings now.
Okay, sorry to bring this to a halt, but we're coming up to our deadline in terms of time. In the chat box, there are relevant emails, so please follow up with the people. It's been a very interesting conversation and one that will continue, because I think this is, as other people have observed, this is very much a journey. But I think the point we're at now is very different to where we were certainly 2 years ago. And the system way of working should help that. The only other reflection I would have is that for those that have seen the new ICP integrated care system strategies, some have really linked through a carer offer through there. Not all, but some have, and that is really expressing that not so much in terms of data, but in terms of ways of working. And I think that gives us some cause for optimism as we move forward in that way. So I would just thank the speakers very much for the conversation we've had, and it's a conversation that will continue. And I thank you all for your contribution to this. Unfortunately, we haven't had time now for input from each of the systems, but if you wish to share that, and we will be very happy to circulate that if you would want to do so. So thanks as always to the speakers and to Steve for organising this and doing things on the day. And I hope your rest of your day goes really well. Sorry, Debbie, quickly.
I just wanted to say thank you very much to the National Carers team for putting on these events. They are really, really valuable to us all working at system and regional level. So a big round of applause to you, Paul, Verity, Steve, and our colleagues in the national team.
Thank you. Campbell, before we leave.
I hit the wrong button, Paul. I meant to do that clappy, icon-y thing.
Well, I think that's the right way to leave. Anyway, thank you all and have a good day. Thank you.
Bye-bye. Thank you.